So Wednesday and Friday I'll call that. Today, but it's actually hard to fit 3 days in a row.
It's hard to sit through it in general.
I think I'm not
Get it over with once.
Yeah, exactly.
Yeah.
So Wednesday will be my first day.
Okay. All right, we'll go ahead and get it started. One. So, thanks everybody for joining us today. Sorry, I'm not going to slam so hard. We'll get started on our educational session. For those of you on the phone, we did put in a SurveyMonkey link. If you could fill that out after the session, we'd love to get your feedback on that. And also, if you could, on the phone, put in your name and your facility that you work for into the chat box, making sure that you post that on the everyone section so we can get your name put down. And so with that, Martha, we want to introduce our speaker.
Yes. So today's speaker on UTI surveillance is Kathy Pierce, our secretary, and she has been a nurse at St. Luke's for 20 years. In med-surg, mother-baby. Prior to that, she was an X-ray tech. And she's done 9 years in infection prevention, and she opened the Meridian Hospital infection prevention, and is now in rehab, long-term care, and short-term long-term care. And a fun fact is that she is going to go to the Lawrence Welk Resort and play golf.
Oh. Who knows who
the question is? Yeah.
You're old, right?
We're really old.
Where is this resort?
San Diego.
San Diego.
Oh, San Diego. Wow. I was there last week and it was beautiful.
Ah, nice.
Not the Lawrence Welk Resort.
No, I said Lawrence Welk. I told someone at where I was working and I was going, and I was like, "Do you know who Lawrence Welk was?" She's like, "No, she didn't." I said, "Well, then I know you're young." So
I do that with these guys all the time. I'm like, "Oh, so and so died." They're like, "Who?" I'm like, "Oh my God, you guys."
Our long-term care still watches Lawrence Welk every week.
Oh,
It's one of their activities.
Funny. Did you want to, are we going to introduce or are we just going to go?
Yeah.
Okay. So I'm going to talk about UTI surveillance. I have to say that I did not create a lot of this information. It's from the NHSN training. There's 2 trainings. There's one usually in March on acute care hospitals, and then there's one in July that's on the long-term care. And I usually watch both of those because I'm at the rehab hospital, so my 2 units, I have one floor that's inpatient rehab unit, which goes by the acute care surveillance definition, and then our 3rd floor, which is subacute rehab unit. It's really what I call short-term long-term care because long-term care they're there for a long time, but our average stay is about 2 weeks, and they go by the long-term care definition. So sometimes I get confused. I have to really separate the 2 things. Which room is this patient in? So I know which one, because they are different. So hopefully we can get through all the slides because I have both the acute care and the long-term care stuff. Do you have anything so I can?
I
you want to try it
for you. Can you do it? Or maybe she can do it. It's not working with phone.
I can rush make it. Work.
Make it right.
Okay. So we're going to try to talk about both of these.
Or you can do it down there. Yeah.
Okay. So first I just want to talk about the UTI burden. In 2014, there were 169,961 CAUTI, which equates to 5.7 CAUTI out of 1,000 discharges, right? In 2017, the number had actually gone down by 5% to 160,833 CAUTI, which is 5.4 CAUTI per 1,000 discharges. And it's good that we saw a decrease. I think that with all the CAUTI bundles and all the implementation everybody's trying to do, I think it's working. CAUTI's numbers are coming down. I think that's great, but UTI does still rank as the #4 HAI in the U.S. And the average cost of a HAI for CAUTI is $13,793, which, whew, that's a lot of money. I don't know about in the inpatient rehab arena and in the subacute, we get paid a flat fee for patients. So if they have it and they stay longer, we eat all that. All it, anything extra that they go into, it's all one fee. So this shows you that, the cost for things go up and our fee back goes down. UTI prevention begins with surveillance. And I put this slide in here just because there's so much information that we can't even go through all of it today. The NHSN training, it's a 3-day training, and they're talking constantly. So we just can't even go over all the information, right? 3 days for both acute and for subacute or for long-term care. So there's just a lot of information, and if you really want to get into all the stuff that they are willing to tell you, you can go to this website, and this will be on the slide. More than free to go there. I recommend going there. Training, protocols, they have frequently asked questions. There's all sorts of good stuff on this website. So I just want to make sure you guys have that in there. Now, I know that most of you that are already doing surveillance for I'm going to get myself confused too. But the Chapter 2, which is in the acute care hospital side, are probably already doing the CAUTI, UTI surveillance, right? So it felt like when I was putting this together, well, maybe we should have done this back in January because that's when you should have known about the changes that came from 2018. And this being September, they're already getting ready to put out the 2020 changes to the surveillance definitions, but they're not quite ready, which is what they said. So you'll have to do all this again, or at least go through the training again in January so that you know what the changes are that are coming. But this is what currently they have. And I don't know that any of this kind of stuff is changing, but there's the 7-day infection window period we're going to talk about, the date of the event, and the UTI repeat infection time frame so that you can apply the surveillance definitions and make sure you're calling a CAUTI, and a UTI, and not putting stuff that shouldn't be included in your surveillance. So the infection window period is defined as the 7 days during which all site-specific infection criteria must be met. I use that little thing down at the bottom. I have it's dependent on the first positive diagnostic test that is used as an element to meet the site-specific infection criteria. So whenever I'm in doubt, I always plug that in there and I go 3 days above, 3 days below, and I have to count in my head because you want to make sure because if you have a fever that meets the site-specific criteria, it's the only thing you have, but it was 5 days before, it's not going to meet criteria. So make sure that you have your infection window period, it's a 7-day span, which all the site-specific infection criteria have to be included in that. And if I'm going too fast or if I'm not making sense, let me just stop me. Okay? All right. Laboratory specimen collection, imaging test, and procedure or exam are considered the diagnostic tests to use those to meet that element. Oh, there's a blank slide. That doesn't seem right, does it? There we go. Oh, that's right, because it was my animation, that's right. So the first positive urine that is used to meet the definition always sets the infection window period. So you get that first culture, you put that in the middle of your 7 days, you count 3 days up and 3 days behind, so that when you're doing your investigation of the rest of the chart, they have to be within those dates. And only eligible UTI elements within the infection window period are going to help you meet that criteria. So it shows you, like I had talked about, the signs and symptoms the day before that infection window period. It's not going to meet criteria to be a UTI. Date of event is the date the first element used to meet an NHSN site-specific infection criterion occurs for the first time within that 7-day infection window period. It can be a culture or a sign or symptom. So it doesn't have to be the culture on this one, but the culture sets the window, and then all your signs and symptoms have to fall within that period. For the repeat infection time frame, there's a 14-day time frame where the date of event is day 1. So it's really important on that slide that we talked about before that you get the date of event correct, because that's going to set your day 1. And then no UTIs are reported, specifically SUDI or ABUDI, and all eligible pathogens from urine cultures are added to that event. You don't change the device association during the repeat infection time frame. And any UTI criterion set as a repeat infection time frame sets the repeat, including present on admission events. Does anybody know what the SBAP means? SBAP, I don't know. To be honest, I was reading that. Secondary.
Yeah.
So that's for the ABUTI, then that's what they're supposed to be talking about on that one. We don't get many of those because our doctors will only do the culture, the urine culture. They never, in the long-term care setting, ever run a blood culture. Yeah, it's kind of strange. I did want to say I found a couple of interesting facts on these that if you're going to put this stuff into NHSN, you have this repeat infection time frame, and you can have two cultures, but then if you have another culture that's a different one, that third one, you can't enter it, so that it looks like it's a repeat infection time frame. So I think there's some bugs in this when you're going to enter, just so you know. This is what I use. This is my personal thing that I use to show I have present on admission, which are these. So if something occurs, or like the date of event falls in the day before the patient was admitted, or 2 days before, or the day of admission, or the day after admission, is considered present on admission. And then you have to go and see when your 7-day infection window period is. And so that's why I put that in the middle column, and then I have the date of event so that I can figure out when my repeat infection time frame is supposed to start. And I have to admit, it gets kind of confusing when you have somebody that is on the acute care side, and they have the acute care definitions, and then they come into the long-term care side, and you're trying to figure out, well, was it an infection that this one falls in, the one on the long-term care side fits within the repeat infection time frame, but the criteria are different. So then it's like, well, which criteria do I use? So I heavily rely on my little graph here so that I can figure out, because otherwise it gets so confusing.
NHSN has one too.
Yeah, they have a worksheet generator.
They have a worksheet, but you can't print it out. You have to just put your dates in, and the one that you put your dates in, and then it drops you. But so how do they do the different criteria? So if one of them's an acute care side criteria, one's long-term care criteria. Yeah. So that's why
the rest of
I try to
it is
separate it.
separated.
Yeah. So.
And I do use that one sometimes, but particularly on confusing ones.
Yes.
Yeah.
I'm trying to figure out POA.
I start putting in the dates, and then what happened where, when the Foley was in, because I have to have it all in writing, because, as you age, your mind doesn't have that flow of thinking, right?
I agree with
I feel like these are out of order, but the urine culture, where's my definition? It was on that flip page or something. Okay, so those are kind of out of order. We'll go back to those. So there are two specific types of UTI. Symptomatic UTI, which is both a CAUTI and what I like to call is a SUDI-1B, which is non-catheterized UTI, and then the ABUTI, the asymptomatic bacteria UTI. Both types, if catheter associated, must be reported as part of any CMS CAUTI reporting requirements. So those of you that do report your CAUTIs and stuff, do you guys know if you report your ABUTIs?
Yeah, we've had some.
Mm-hmm. And
It's kind of rare.
Yeah, that's
happen very
okay. So
often.
it's rare for you as well. Okay.
Yeah.
Do you guys know if we look at those very closely?
Well, we typically look at it when we're working up like a class C, then we'll know.
Mm-hmm.
Oh, okay.
And then when
So that you can go back and it's just the class C is the secondary infection and it can go to a UTI, right? Okay. That makes sense. CAUTI. Yeah. Indwelling urinary catheter. The first thing you have to have a CAUTI. And I have to tell you that one of the long-term care NHSN training things, the gal wanted to call it a CASUTI. Because she wanted a CA-SUTI, because they're all SUTI, right? So through this whole thing, I'm watching CASUTI. I'm like, oh my God, not another one. Because, some people pronounce it CAUTI, some people pronounce it
Howdy.
Yeah.
And then there's a CASUTI. So there you go. But, indwelling urinary catheter, drainage tube inserted into the urinary bladder through the urethra, the only ones that count. It's also called a Foley catheter because the guy Foley that invented it. But they're the only ones that go through the urethra, so there you go. Not an indwelling urinary catheter. If you straight cath, have a condom cath, in and out cath, and now they're going to have to add that female external catheter on there, right? Because that is not an indwelling.
Also suprapubic.
And suprapubic, that's right.
Mm-hmm.
Yeah, that's true. Yeah, they should have that. So here are the criteria for the SUDI-1A, which is the catheter-associated urinary tract infection, or CAUTI. The patient has to have had an indwelling urinary catheter that's been in place for more than 2 consecutive days in an inpatient location on the date of event and was either present for any portion of the calendar day on the date of event or removed the day before the date of event. They have to have one of the following signs and symptoms: fever, where am I at? I got a thing that I got distracted. Fever more than 38 degrees Celsius. If you're choosing fever in patient, that's the one where you have to be less than 65, right?
Mm-hmm.
Right. That's the one that gets tricky too, isn't it? Suprapubic tenderness, costovertebral angle pain or tenderness, which they never, the nurses never put down costovertebral angle pain. They say back pain, low back pain, flank pain. It's always something different. And for the suprapubic tenderness, it's going to be low abdominal pain. It just can't be generalized abdominal pain. NHS says it's not specific enough, but it can be low abdominal pain. That's specific enough. Urinary urgency, if the Foley was taken out, a urinary frequency, or dysuria. And there's no other recognized cause. And obviously those symptoms, you can't hopefully have urgency or frequency if the Foley's still in place, right? So those have to be if the catheter was removed the day before the date of the event. The patient has to have a urine culture with no more than 2 species of organisms identified, at least one of which was a bacteria of greater than or equal to 10 to the 5th. Which, a lot of times, a lot of those cultures, you can just rule them out right off the bat because they do not meet the 10 to the 5th. So right there, they're just gone. You don't even have to look at the rest of it. All the elements of the UTI criteria must occur within the infection window period. I know you guys, most of you all really know this, so chime in there. Okay, knowledge check. If the patient complained of urinary frequency on 3/28 after the IUC was removed, can it still be used to meet SUDI? True or false? It can still be used to meet SUDI. True or false? True. Everybody agree? It's true?
Yeah.
All right, very good. And would it be a SUDI 1B or a CAUTI? CAUTI. All right, very good. Any questions on that? That's pretty straightforward. SUDI 1A, so a CAUTI example. I think that's the same. They had frequency on the day it was discontinued. They didn't have a fever, but they did end up meeting that culture. Mm-hmm. So 1, 2, 3. So I always have to count backwards. It does fall within the 7 infection window period because it's 3 days before, where you have the frequency. Does that make sense? All right, SUDI 1B, non-catheter associated. Basically, it's almost identical, except for that the patient did not have a Foley in the date of the event nor the day before the date of event. So they have all the same signs and symptoms, with the fever if they're less than 65 years old, suprapubic tenderness, costovertebral angle pain, urgency frequency, or dysuria. They all have to be within the infection window period. And here's our little example. I can't quite read the thing on the right. The 613 culture cannot be used because there was no bacterium greater than 100. They were 10 to the 5th. Because what they had a culture of Pseudomonas aeruginosa.
Right, it was 1,000.
Yeah.
And, yeah.
So you can't count that one for the date of event. So the infection window period, right, starts on that day that culture was taken, the one that counts, 3 days before, and that's why the fever that's way up high falls out because it's not within that infection window time frame, 3 days before and 3 days after the date of the start of that window, infection window period. And then, so then the fever on the day the culture was done becomes the date of event. There's no IUC in place, nor on the date of event nor the day before, so that's why they meet the SUDI 1B, and then that sets the routine infection time frame and the SBAP. All right, cool.
Kathy, how old is that individual?
How old are they?
Yeah.
I cannot read from here. What does it say?
It doesn't say.
No, it doesn't say. So they might it's young. They're less than 65,
okay,
right?
Yeah.
There you go. They must not have been just left and blank. That was a good question, though. So I don't deal a lot with the kids So CODI or non-CODI patients less than 1 year of age is more up your alley, Amy, right?
Yeah, except for, they very rarely have catheters unless there's
Oh,
some
okay.
relationships, mostly they're diapers, so.
But this is CODI and non-CODI,
Yeah,
but they're usually not verbal too, right?
yeah.
They're less than 1 year of age, so you have to just go with, that they show the signs and symptoms through crying and that kind of stuff, or?
We do track those
Do you?
non-catheter associated, and I hardly ever see them with kids, and really,
Is that right?
in
That's
3
good,
years,
though.
we've had like maybe, we had 2 in the NICU about 3 years ago, and then I think we've had 2 maybe in pediatrics, 2 or 3
Okay.
in the last few years. It's just not very good, they don't
Right.
have catheters very often, so you don't have catheters.
Well, you know, what I think is interesting too is the signs and symptoms that you're looking for, they could oftentimes be attributed to something else as well, right? So it's the fever, hypothermia, especially if there's just one of those, apnea, bradycardia, lethargy, vomiting, suprapubic tenderness. As soon as people, you know, during flu season, when they start vomiting, they have the stomach flu. There's no such thing as the stomach flu. Patient has the urine culture, they still have to have that, meet that thing, and then all the rest of the things, they have to fall within the infection window period, and you set the date of event and all that other kind of good stuff. So here we go to the beauty, the asymptomatic bacteremic urinary tract infection of any age. They, as with or without an indwelling urinary catheter, but if they have a catheter, you have to report that to NHSN. They have to have a culture with no more than 2 species of organisms, you know, and still meet that 10 to the 5th. And then they may not have any signs, they don't have any signs or symptoms that we talked about for the urinary tract infection, but they'll have an organism identified from the blood specimen. That's why it's asymptomatic bacteremic, which matches the bacterium on the urine culture. Still, how it has to fall within that infection window time frame, and that LCBI. Amy, you're better with that. I do not ever have any LCBI.
Laboratory confirmed bloodstream infection.
Yeah, but I mean, then you look at other criteria, right, for that? So that it doesn't, you don't have to count that as a CLABSI at that point, right? You still have to count it as a CODI.
It would be
As a booty, yeah, right, unless you had another.
But if they have a catheter, then you still count it as a CODI in NHSN. Does that make sense? Boy, there's like so many tiny things on these things. I already talked about that one. There's your example of the asymptomatic bacteremic UTI. They were admitted on the 20th. They didn't have any UTI signs or symptoms, but they had elevated white blood count and a positive blood with Staph aureus and a positive urine culture, same thing. So, still they never had any UTI signs or symptoms. Now, this is totally different when you get into long-term care because, well, we don't run very many blood cultures, but the patients may not be having any of the signs or symptoms that they're looking for on the, to meet criteria for the NHSN, and the doctors will get a urine culture, and they have just a little bit of positive in there, you know, it might be 10 to the 2, and the doctor will call it a UTI and start giving them antibiotics.
So it's not a diagnostic-driven thing?
It's not like a criteria where you go through and you have to meet the
No,
criteria.
for the doctors, I mean, it's not like,
You know, they do more on
Okay.
symptoms. They look more at symptoms. But, you know, that's kind of when you get into the long-term care setting, people over a certain age are going to have bacteria in their urine. So when you throw a lot of antibiotics at people that really shouldn't be getting, if they don't have any signs or symptoms, they shouldn't be getting antibiotics.
So what about the unconscious patients?
Yeah, well, I don't have those in my facility. They're in ICU. I can just give those away. But,
Or people
can you?
can't
You
verbalize.
can't verbalize, right.
That's a challenge.
But do you have those other symptoms if they're not in a long-term care setting, say they're just in the acute care setting? So if they have, they're not going to have dysuria and that kind of stuff because they're not going to be urinating, right? But they're going to have,
The unconscious folks, it's usually fever.
It's usually fever.
Or if they can do, if they're doing a physical exam and they can appreciate suprapubic tenderness.
for rebounding and that kind of stuff? Did they put that in there? So if they're unconscious here, they're probably getting antibiotics for something, right? Usually. On this one, the date of event, just talks about the date of the event is the same day the culture was drawn, 3 days before, the 3 days after, and then whether you really have that, you have to report that. Maybe they think people aren't reporting it, but I'm going to keep going. So why do we monitor urinary tract infections in the long-term care facility? It's not a current requirement that you have to go in and report these to NHSN. The more information they can get, the better, because it'll help us figure out who has what kind of things are going where. UTIs are considered one of the most common infections in long-term care setting, driving antibiotic use. And like I said, the doctors will diagnose it more often than what we feel the symptoms and that kind of thing dictate. But if you have focused monitoring of the symptomatic UTIs for both catheter and non-catheter associated, helps you identify trends in the infections, which will improve the antibiotic use, hopefully, in long-term care facility setting. And tracking those events will help the infection prevention do targeted prevention efforts and see what's working for them, if you know the numbers beforehand and then the numbers afterwards. So I'm looking to sign up our long-term care in both the rehab hospital and then down in Elmore, just to hopefully get that information in there, because that's the only way you can actually look at your comparison too, your SIRS and stuff, is if you're putting in data, then you get to have all that other stuff. So I hate not having the SIRS for the long-term care setting. I left this. So this, I just want to throw this in there. If you go to that website with all the trainings, there are so many good tools available. I really like the little CODI thing at the top. It's a prevention thing, but it still spells out CODI and how to prevent getting a CODI and all that. And then the 4 things you should know about the urine cultures, what kind of toolkits there are, what kind of tools are available. There's all these worksheets. So please go to that website if you have any interest in getting all that there. So now, those of you that have been in the long-term care setting, there's what they've always used, well, they've used since 1991, there was a thing called McGear criteria, which almost, 90% of people pronounce it correctly because we all want to put an R in it, right? McGear. But it's McGear criteria that started using that in 1991. It's different for the elderly and for those, because most of those in long-term care are elderly. They did revise it in 2012. Shea and APIC was involved in 2008, but then Shea came out with this in 2012. They made changes to improve surveillance consistency and to decrease the surveillance burden, right? So they have a lot of different, the McGear is definitely different from NHSN, and then if you'll see here on NHSN, you have signs and symptoms that are considered nonspecific and may be applied to more than one infection cause, whereas in McGear, you had to look for other sources of infection before using the fever, rigors, and hypotension. And it's a call-out right on the McGear criteria when you're looking at their forms. The CAM criteria for NHSN are not required when you're applying a new onset confusion functional decline, whereas for McGear, it's one of the basic things that you have to look at is everything has to be a new onset, because usually those people are there for 4, 5, 6, in a long time. And so was it a new onset to make sure that they really do have a UTI? So you have to really focus in on what's different. The urine culture requirements are not, for NHSN, are not dependent on the specimen collection method. This year, they actually changed it. So last year for McGear criteria, that if they were straight cath and they got the urine sample, it only had to be 10 to the 2 for the culture to count, which, everything's 10 to the, if you have any culture in there, it's going to probably meet that. So it was really hard to weed out anything because of the urine culture not being the right thing. But it was really hard to decide how was the specimen collected. They probably weren't just doing a clean catch. They're probably doing the in and out catheter, but nowhere on our, at least not in our charting, did it ever say. So it was really hard. You had to go back to the nurse and go, do you remember how this was collected? So it really put a burden on the person that was doing the surveillance. The urine culture has to have no more than 2 species of microorganisms for the NHSN. And if it was a voided urine culture, then for the McGear, you can have no more than 2 species of microorganisms, right? But yeast and non-bacterium were not counted for an NHSN, but there were no exclusions for that for the McGear criteria. So the NHSN, they want to say that, consistency is a must. If you're really going to look at things and compare year to year, you have to be consistent with how you're following all the right criteria that from year to year, so that you know that you're doing it consistently, that you have something written out consistently. The NHSN got together with joined with the McGear criteria, and they put out a new thing that kind of takes a lot of the NHSN pieces, components into account, because the McGear never had the infection window period, the infection time frame, or any of those. So you were just kind of started out in left field, and you're like, well, if you're used to using the NHSN stuff, you're, well, what about this? They had this other culture back here. Why can't I count that as a repeat? Especially for those people that were in for 2 weeks, short-term, long-term care. It was really getting confusing. Luckily, you didn't really have to report it, but if you wanted to start reporting it, you didn't know which ones you should be reporting, which ones you shouldn't, because there was no parameters around any of it. So there was no consistency. It made it really hard. With the McGear, when NHSN and the McGear combined, you do have to look at the symptoms new or acutely worse, which is different from, just the NHSN and the acute care side. Does the resident have an indwelling catheter? We always look at that anyway. And then the evidence of infection. They had to have a positive urine culture. Whether or not they had to have, without an indwelling urinary device, they had to have localized signs or symptoms. And what does the clinical presentation tell the doc, right? So what if there's clinical disagreement? Now, this is a big thing. This became a big thing at the rehab hospital because the doctors were having a meeting, and then I heard later on that one doctor went, I know her numbers are all wrong because I know we've had more CAUTIs and UTIs than that. So I put this whole big thing together about there's often clinical disagreement because they never care if the cultures get to the 10 to the 5th. So I put a big thing together showing that they oftentimes do not match. There's different purposes. They may not agree. You're still going to give antibiotics, but we're going to say it doesn't meet criteria to get antibiotics. It doesn't meet criteria to be reported, but they still go on the CMS, the MDS, which is the minimum data set. So it's really conflicting stuff. Hopefully at some point they'll all get together and we can all just be doing one thing. It would be so nice, wouldn't it? Just to be having to give one thing that makes sense. But they really may not agree, and your doctors may get really upset that she's not reporting the right stuff. Really? And so I had to go through each one that I had reported and say why the ones that didn't match. Well, usually it was because they never met the criteria on the 10 to the 5th of the culture.
Maybe they shouldn't have been treating?
Yeah, they really shouldn't have been treating. Yeah. Because then they didn't have the signs or symptoms, the big thing. That's why they think there's just so overuse of antibiotics in the long-term care setting. NHSN does provide a customizable UTI event form with instructions. So you can always go there and change it and then bring it. But
Can you go back to that previous slide?
Okay, how do I do that? Just go.
Well, we don't even really need to go back, but there was one piece on there.
This one?
Oh, yeah, where it says
Or one more.
if there's questions or whatever, you can send it to NHSN.
Yeah. Oh, I'm going to ask you
But
that.
also, I think sometimes the surveillance definition really truly doesn't match the clinical definition, and maybe NHSN should reconsider what they have, and so that's another venue where you can submit that to NHSN, and if they get that, from multiple people from multiple settings and different facilities, and that's when they, reconsider their criteria. So if you don't necessarily agree with it, submit it to them so they know.
But we've also found that you can submit it 2 different times and get 2 different answers.
That's true.
So if you have, and the other thing that I found when I was researching to put all this together is that in one of these trainings at the very beginning, they had, anybody who wants to be a beta tester for the 2020.
Right,
They're going to be
I saw
taking
that.
all that. Yeah, I think that would be really interesting to do that. It's going to be done during October. There's like 2 weeks during October.
Send out the newsletter was on there.
Yeah, that's what it was in, the newsletter, the e-news for September. That if you want to be a beta tester, you can send it in, email.
For the new criteria?
For the new criteria.
That'd be interesting.
Wouldn't that be interesting? I think it would be really neat, yeah. So go find that newsletter and you can do that. But there's the customizable UTI form, so you can always get that. And we talked about all these questions on the website. There's training and protocols and forms and instructions. I know that in the long-term care setting, they often have times keeping a infection prevention person. They turn over a lot, right, Susan? Because we have trouble keeping our lists current.
Turn over a lot.
So, yeah. So, this is a great list. They also have the CMS has the long-term care training as well. Just, it's kind of time-consuming because there's 27 modules. I think I'm only up to 7. Because they're like an hour or 2 each.
It's a good training, though.
It is really
Yeah,
good.
it is. It's very
Starts
good
out really basic,
foundational.
especially if you haven't done anything. And I've been doing it for 5 years, and I never knew how the QAPI and the QAA fit together, and it tells you, right? And I was like, yay, I now understand it. What a good deal. Date of event, this is all just kind of the same stuff, they just present it differently. They talk about a urinary catheter. I did love that the one long-term care side, they just flat out told you, no, these just don't count, right? They talk more about the nephrostomy tube and the suprapubic catheter, whereas in the acute care side, they did not have that. And this is all from this past year, so I just thought it was funny. Yeah, both types. We already talked about that one. I'm going through faster than I thought and so questions to ask when you're trying to decide if they have an NHSN qualifying event. For the symptomatic, does the patient have an indwelling catheter in place, or was it removed the 2 calendar days prior? So I coordinate with the MDS coordinator at rehab because she has to enter stuff on that side, and she always looks to me to say whether or not you call whether it's really a UTI, what kind of stuff. And she likes all her stuff in these kind of little, because she's visually different. She learns differently than I do. So we made all these little visual things so she can tell how the criteria go down. But then she always asks me, does it meet or doesn't it meet? But it's funny how you have to, sometimes you just want to look at it differently, right? Because it all says the same information. Mm-hmm. But I had it all listed out like this, and she wanted it in the little pictures, leading, like more like this leads to that, and if it's here, it's just out, more of the algorithm kind of thing. But, so these, you have to really, it requires more investigation. So this is the one, the SUDI, without an indwelling catheter. There's 3 criteria options when you have to have a positive urine culture. And luckily this year, like I said, the urine culture has to be 10 to the 5th or greater. So for criteria 1, you either have to have acute dysuria or acute pain, swelling, tenderness of the testes, epididymis, or prostate. So if my patient, I go in there and I start looking and they don't, female that doesn't have acute dysuria, I know, I'm just throw that one out because it's, all the rest goes to a man. So I go to criteria 2. Do they have a fever and leukocytosis? But they also have to have one or more of the following, right? The CV8 pain or tenderness, suprapubic pain or tenderness, visible gross hematuria, incontinence, urinary urgency, or frequency. And if they don't have the leukocytosis at the top, for criteria, criteria 3 talks about in the absence of fever or leukocytosis, you have to have 2 or more of the following, right? Then it's 2, because on the criteria 2, you only had to have 1 of the signs or symptoms if you had either fever or leukocytosis. Whereas then for criteria 3, you had to have 2 or more of the following signs or symptoms to meet the criteria. So there are 3 criteria.
Is it acute leukocytosis? Is there any criteria for?
There are no parameters around it.
Oh, okay.
So I usually look back. That's why I liked when they went to the NHSN. I try to keep everything within that infection window period, because that's why NHSN just gives more parameters around all of it. Because, like they combine, this is a combination of the NHSN and the McGear. And the McGear, it was just all a free-for-all, in my opinion. I mean, a lot of people really like to use it, but there were no parameters for present on admission or infection window period or repeat infection time frame or any of those. So since this is an NHSN long-term care component of that manual, I use all the definitions I've wanted, the chapters 1 and 2, which are the infection window period. So I personally find it has to fall within that window. Yeah, because what if it was 2 weeks before?
Or if they've had sustained leukocytosis for the past 2 months.
And so a lot of the stuff is usually new or marked increase, but usually only for the signs or symptoms. Yeah. So that's interesting because that's their baseline.
So then do you just go to the doctor's chart notes, or do you have it flagged so it brings it up where your bigger facility? I just know that when I'm going through, I have to go through to see if there's the Foley's, and I have to go through each patient, which we don't usually only have maybe 10 a month, so we're little. But so I go through each doctor's chart notes to read to see if it meets that. But is there a way that you, or do you just look at the very beginning?
We start with the lab, because if they don't have
leukocytosis, and then
from the very beginning, just even if you back out a little bit, the first thing they look for, do they have a positive urine culture? And it has to be 10 to the 5th, or I don't even investigate.
So then do the labs say 10 to the 5th? Because we don't, but our policy would be we wouldn't send it for culture, but we wouldn't send it for culture unless it was that, or unless it was less than 3 morphologies. So that's where you.
So if it doesn't go to
start.
culture, you can't ever meet this criteria.
Right.
You have to have that.
Okay.
So if they only just
start
do
at the lab,
UA, and then a micro.
If the lab's there, then you go to the chart notes to see if the doctors documented the rest, like the FW routine or what, that.
Or the nursing staff, yeah.
Oh,
It doesn't have to be the doctor
The nurse.
documenting, it could be the nurse documenting.
Nurse notes, okay.
Yeah. And the more you find out what the criteria is, the more you can teach your nurses, because, like I said, a lot of times they won't put it in the right wording.
Well, that's what I was seeing that wording, and I'm like, I don't think I've ever seen some of that wording in any of the charts I've looked through.
Well, that's why
excited
the
to ask
NHS
that,
thing
yeah.
is nice too, because you go back to chapter 2, or even at the bottom of this chapter that this is all in, and it tells you what kind of wording will qualify for that claustrovertebral angle pain.
Oh, okay.
What kind of wording can you look for the suprapubic?
Okay.
It can't be abdomen, because they said that's too generalized, but it can be lower abdomen, which is basically right under the suprapubic, that counts.
Okay.
So, and the same thing with the claustro, it can't just be back pain, it has to be, one side or the other, or mid-back, or, so there's specific parameters around it,
Yeah,
which is
because I'm
what's
like,
really nice about the
that's
NHS.
pretty specific.
Mhm.
Yeah, I was like, I don't think I've ever seen that specific, but I see now.
Yeah.
One thing I think is interesting for the long-term care criteria is that you can use a fever in any patient at any age.
And
in the
they're
criteria,
mostly over 65.
but you can't in the inpatient,
I
which is,
know, and I don't know why they changed that, because it wasn't always that way.
because it's frustrating when you have a patient that's like over 65
I
that
don't
has
know
a
what the
fever,
reasoning is for that.
like before they had the catheter in place, and then at day 2 they still have their fever, and then it pumps culture, and you can't call that
Right.
POA.
Yeah. What's interesting too about the fever here, so this is, goes on about the fever, right? So you can have a single temperature, and the fever on this is lower than the acute care side, because you guys are 38, right?
Right.
So this one is 37.8, one time, or 37.2 on repeat occasions, or a 1.1 increase over baseline. So when I go into it, I try to open it up and I try to see what the baseline is. Is it really 1.1? I mean, it's just like,
do you
please don't
establish
meet
it?
that one. So yeah, because it's hardly. I've never seen it raise that.
How do you establish their baseline? Do they have?
I just,
I see it right
I look it on the chart and then
average of their pre-respective temperature.
And you know how on ours you can see a line, so then does it go up suddenly? And that's usually what, flip up is usually what tells me. But most of the time it's going to be over that single temperature anyway, unless their baseline's really low. But it's a non-specific sign that can be used to meet the criteria. In the presence of another possible infection source, they even have a call out on the McGear criteria where it says that they think that fever is usually related to something else and it really shouldn't be called for UTIs. And that's why it's more specific. It usually has to be combined with something else, where there's signs and symptoms, or that leukocytosis.
How long do you look for their baseline?
I'm sorry?
Like, you have a time frame that you look for their baseline?
I usually try to open it up to at least a week, if not 2 weeks, to try to see what their baseline is before, because in the long-term care setting, we don't take vital signs as often either.
Yeah.
So it could be quite a ways, it could be a week ago that they even took the last temperature. So I try to open it up and try to,
Kathy, what is the minimum time frame that you take vitals? Like, what would be the minimum frequency that you would do it?
I don't know if there's a minimum. In Elmore long-term care, we take it once a week. We take it once a week unless they start having problems, and then we start taking more often.
So, you have to go back a ways to look for a trend.
Sometimes you do, right, to see what the baseline is.
Yeah.
Now, if it doesn't, usually if they start having a problem and they took it, then they'll do then they'll do it.
But that's
that
not
point.
the baseline.
But that's not the baseline. So that's when you have to go look to see what is the baseline really. Yeah. Leukocytosis, an elevation in the number of white blood cells in the blood, and their left shift. And I don't know how many times I've had to call Amy and go, tell me again what left shift is? Where do I find it? Because in our reporting, they don't say bands. So how am I going to know if the bands are greater than 1,500? They don't say bands, you guys, on our...
It says immature neutrophils.
Okay. But then there's two of those. There's a percentage and a something count, and I never know which one. That's why I always call Amy. Tell me again what I'm looking at. I can't tell if it's left shift or not. Please help me. It's on the CBC differential blood test. Make friends with somebody in your lab so you can call them and remind you what the left shift is. I don't know why, I just can't remember it. Examples of a SUDI without an indwelling catheter. So Mrs. Stevens, she's in a nursing home. She developed new increase in incontinence and new suprapubic pain, and then the next day she had a voided urine specimen sent to lab and subsequently tested for greater than 10 to the 5th E. coli. She does meet the criteria for non-catheter associated UTI. She had the new incontinence, new onset of suprapubic pain, she had the culture. You know, and the nice thing about this is that a lot of times in the nursing home, you know, they have trouble standing or that kind of thing. You see your collection is often contaminated, and you go back to that one person who did 3 in a row, and they were all mixed flora. Mm-hmm. So then, you know that there's kind of an issue getting it that way. So you can either, you know, it's just not, you can't use it whatsoever, but you're worried that there's a patient that really does need the antibiotics, but you can't look at it and find it, and are they going to give it to them? If they really know what the criteria, they may not. So sometimes it's just better to go back and get a straight cath and get a sample, because without the contamination, hopefully. Catheter-associated symptomatic UTI, or CASUTI, okay? Resident has an indwelling catheter that's in place greater than 2 days, and they had one or more of the signs and symptoms, and they had a urine culture that met the criteria, then it was a CASUTI. So here was this one's a little bit more straightforward. You don't have all the 3 criteria that you have to go into. It still does the fever with the single temperature or on repeated occasions or an increase over baseline. But then you also look for rigors, new onset of hypotension, new onset of confusion, which I find interesting that, you know, because a lot of people, if they start getting confusion, the doctors immediately do a urine culture, right, for the elderly. And if they're confused and they get positive,
That's an old practice.
right.
They are changing that.
But for NHSN and this criteria, it's only on the catheter side, not on the side without a catheter. Confusion is not part of the symptomology. So true. And you have to look at the acute functional decline. So you have to look at the activities of daily living and what the points are, and then did the points go up? And they had a left shift leukocytosis. If they even ran a CBC, right? Half the time they don't even have one of those. But you have to look at both of those. And new or marked increase in suprapubic pain. And that's another hard thing. Was it their baseline? Are they always having, you know, back pain? Is it the right kind of back pain? Is it their, you know, you hope your nurses are really charting really well. Acute pain, swelling, or tenderness in the testes, epididymis, or prostate, and whether or not they have purulent discharge from around the catheter. So the one that I was investigating, they didn't have any. I went through the fevers and the rigor, you know, because they'd had a positive micro, new onset, and then I had to go and see that the gal, she made sure she changed the Foley before she gathered the sample, and on her little notes for changing the Foley, he had pus discharge from around the catheter. Dang it! Darn it! So that counts, and I don't count it. Yeah. But hopefully they're charting well and doing the right thing, so you can call the right one. Hypertension, vital sign parameter for facility policy, practices for clinical practice, to non-specific signs can be used to meet the criteria even in the presence of another possible infection source, but you do exclude it if documented non-infectious cause, such as new medication and it's dropping their blood pressures down, or cardiac event. So, new onset of confusion, or functional decline, new or worsening. So they can't just be confused all the time. If that's their baseline, you might as well just go on. But if, you know, one day, and we see that, I do see this down, especially down in Elmore long-term care, you know, the patient's nice and all, and they just get really, they're mean to everybody, they're saying really bad things, and they got really confused, and they say, where's their baby, and someone took this, and like, wow, yeah, that's new onset right there. Now it might, you know, they might clear up because they get antibiotics, and then, you know, a month later they have the same. And so it's still new onset, right? It's interesting. Here's an example of the CASUTI. Ms. Ross was a resident in your facility. She had a Foley inserted, and then the nurse practitioner documented that she complained of suprapubic pain. Probably not in those words, right? Because we never see that. But the specimen was selected. What's that? Hey! For our sample, she had E. coli and Candida, and she did meet NHSN criteria.
Yeah, I have to go in and.
Do you want this back?
I could do it that way, I think. If we meet it that way, then they can't hear us. The rest of the people can't hear us.
I didn't use them.
Oh, okay, I think,
Oh, you can do it from there too.
I just don't know the stuff.
Do it from there.
okay. I don't know if the other people will be able to hear.
So it's just an example in there, you know, all these things are on the website if you guys want to dive deep more into this. Do I have anything else? The asymptomatic. So we still do look at all the three, you know, the SUDI, CASUDI, WUDI. I just love acronyms. I'm sorry. I think it's funny. I cannot quite read that from here. And I just got new contacts. Good gravy. Okay,
For the long-term care, they use the same, looks like almost the same criteria.
So, well, we don't say it changes the word resident. We don't call them patients.
Well, because right here, the yeast is not acceptable in UTI pathogens, but.
Is it in the acute care side?
No, but I thought in the criteria you were showing that long-term care that you would apply.
No, it says still does not. I think it's
not.
Yeah, it's years. But once NHSN got it, it does not qualify.
Okay.
Yeah, but on the gears it did.
Oh, okay, that's what it was.
All right. Oh man, they really handed that you have to call it if you are reporting, CODIs and they have an agouti, you have to include it in there and make sure you call it if that culture is present. Asymptomatic bacteria is not included in the NHSN surveillance definition. You know, and UTI is only one of the things that we look at in the long-term care setting. We look at a lot more infections than they ever do on the acute care side. We look at skin or soft tissue infections. We look at GI infections. We look at, who else is here can help me with respiratory? Respiratory, right? And I want to say there's one more, isn't there? Wounds. We look at wounds. So that means skin, soft tissue. I finished 5. I'm drawing a blank.
Urine? Did you forget urine?
I want to forget urine all the way around, you guys.
Baker City. If this is an emergency, please call 911. For all other concerns, please leave a detailed message with your name and phone number.
Hold on for a
Thank you. Bye.
Record your message at the tone. When you're finished, hang up or press pound for more options.
If you're doing both, it's just hard to keep them separate, but you have to, each one is different. There's a lot of similarities, but there's a lot of differences as well. But I like that NHSN is getting into it, but right now all they have are UTI. I'd like to see them have one for all the rest of them, so that we can use the infection window periods and the present on admission. Because, if they go and they stay somewhere a week and they come back, why do we have to own those? I don't want to own those, right?
I know.
But there's no parameters around it for the McGear, so it's frustrating.
Are there any questions for Kathy or any thoughts from the group on that?
Does anybody know if the NHSN ever allowed yeast in?
They did.
How long ago did they change that?
It changed in
like
2015.
Was it 2000?
It was 15 or 16.
Yeah, I was gonna say 4 years or so.
They most definitely did.
Yeah.
It was a source of contention.
It was.
It really changed everybody's,
Yeah,
everything changed.
Well, because Dr. Kaufman says that if it's yeast, it's usually because they had a bacteria, and now you just waited to test so long, and now it's yeast. So it's usually just a precursor after what would have been a bacteria. But it doesn't count now, so we don't have to count it. Good question.
Does anybody know about the hypertension? How much does that usually drop their, their blood pressure and stuff like that?
So it depends on your policy, but I mean, typically it's, below 90, over 50.
Yeah.
Wow.
Or whatever your policy is.
But it's a new onset, right? So
I
it's
just
a
wondered
normal
personally because my mom had last weekend we had to take her in because she had taken all of her meds in her little pill thing that day, which is really uncommon. She's usually good, but it was the confusion from a UTI we found, but her blood pressure was really high, but she'd also taken blood pressure medicine. But I'm like, well, maybe that was from the other.
But couldn't the confusion have also been from taking all of her meds at once?
But we think that's why she took it, because she did have a bad UTI. Anyway, it's just interesting about the blood pressure. I didn't know that was a criteria.
Yeah, that new sudden onset, that drop, and that's really the word you're looking for on all of them, new sudden onset.
Yeah. Interesting.
Any other?
Kathy, I have a question for just your, anybody where there might be a suspicion of a UTI. You guys use UAs in long-term care?
You do?
Is that typically where the whole thing starts?
Yes. And usually the doc, you know, since it takes 2 days to get the results back, they'll usually, you know, treat on the UA.
Yeah.
Even if you only just see one trace of blood in the thing, they'll start treating it.
How do you get a clean catch on long-term care?
Now, that's what I think. I don't really think it's all that easy to get a clean catch, and that's why you see a lot of it. And that's, you go back and recommend, can you get a straight catch? Yeah. Because it's really hard.
They just refuse, because they have that right to refuse.
They do.
And we have a lot of ours that will refuse the catheter, because if you ask them, they're gonna go no. And so they refuse the cath even though, and so we'd try like 2 or 3 times to get a clean catch, and so they'll end up just treating them anyway, because we can't get a clean catch and they refuse the catheter.
Which is really kind of sad, because then we're just giving antibiotics and you have no idea. Yeah. And you don't even know if you're giving the right antibiotic.
Oh, right, yeah.
You know? It could have nothing to do with what you're looking at.
Yeah. So what about prophylactic too? So we have one patient that they just put on prophylactic.
I have one
for
on
6
prophylactic
months.
as well.
So what happens with those as far as your in your surveillance and stuff?
Well, so like I have one that's on a prophylactic and then she still had a breakthrough UTI because she met definition, it was just UTI, not a COTI, but because it was a different organism that wasn't covered on the prophylactic.
It doesn't matter for your surveillance.
Right.
Yeah, it doesn't.
So what about just
Is it really a
overall
good thing? I don't know.
policy? Do you have a policy for prophylactic use or?
We don't have anything in our.
I didn't have one, but I don't like him to do that, but I could see this person, it is chronic, all the time, so they just did that. I can see why they would do it, but, it's probably not recommended.
Speaking personally, and maybe it's too much information for you, but, since people over the certain age are almost always going to have bacteria in their urine, right? But I also find that when you start to have a prolapse, in your bladder, you feel like you're having a UTI all the time, and it's not a UTI. It's because you can manipulate things and change it, and then it no longer feels like you're having a UTI. So you have to. I wonder sometimes how much they're checking with.
You are approaching the maximum length for a recording. Finish your recording after the tone.
Is it really a UTI? Does anybody ever really even look at that? It could just be that you're getting that dysuria, and it burns like it should be, but it's really not a UTI. But I don't think anybody even considers that.
Or even
but I
going by
personally know.
smell and cloudiness,
Yeah.
I think a lot of
You reached the maximum length for a recording. To send this message, press pound or hang up. To play it,
On my
3. To re-record it, 4. To add to it, 5. To discard it, 6.
Not after your cloudy and odors, malodorous, because you're just going to
To
be
send
more
this
and more
message,
antibiotics.
press pound or hang up. To play it, 3. To re-record it, 4. To add to it.
Yeah. Okay. So that's true.
That are blowing up, perhaps.
Yeah.
Fibroids that are.
But in young people. But it happens a lot, I think, in long-term care, and nobody ever looks at it.
Yeah.
Good point.
Especially with people with chronic.
When you see it's chronic and they put them on antibiotic rather than maybe treating, maybe we just need to lift it up a little bit and you wouldn't have the symptoms.
Or fibroids that are going right into the bladder.
Right.
Well, it looks like we're at time, right around 2 o'clock, so is there any other last minute?
Okay, I do have CIC questions. They're all UTI focused. They're on the website if you want to still look at them. They're in there.
Yeah, we'll post those. Any roundtable discussions, last minute things?
Actually, could everyone fill out
Fill
a
out your
evaluation of
survey.
today's?
If you're on the phone, there's a link.
I strongly agree.
Yay! Oh, you're so good to me. Yay, she gets a plus.
All right, well, thanks everybody for coming. This will be the last meeting of the year. We will start having our conference October 10th and 11th. So if you haven't signed up, please sign up. We'd love to see you there. And the other thing is the ballot for our incoming board is open. So if you haven't voted, please go vote. That's open through October 7th.
Is that located on that? I tried to find that on that APIC website.
It is on the APIC website.
Is it?
Yes, under board members. But we can send out a reminder email as well with information on that.
Oh, I didn't look there. Oh, that was just for board members.
It's your board member.
I know, but I.
All right, well, thank you, everybody. end of a